Thank you very much, Dr. Hidayah. Must be quite odd, an emergency physician in a NS masterclass, but I have some background doing ICU rotation. I have a fellowship in emergency and critical care many years ago, plus fellowship with critical care ultrasound. So sometimes I forgot that I have to give a lecture because I feel very relaxed and enjoy listening to intensivist lectures. So my topic today is PoCUS in ICU. So why would intensivists or ICU conduct point of care ultrasound when there are other sophisticated devices in ICU? You have PICO, or at least Edward Science hemodynamic monitoring device and everything. So while preparing this lecture, I found at least these articles and more. So while minority is still debating the PoCUS benefit in ICU, majority support the PoCUS utilization by intensivists. So why? Because there are many roles of PoCUS. So we know that ICU patient is characterized by dynamic and complex multi-organ dysfunction, and any new problem can arise at any time. So PoCUS can have the role to give you a clinical insight in real time. Hence, so it can narrow down differential diagnosis and also guide us to relevant investigation, and more importantly, guide us into resuscitation, which is time critical in ICU. And of course, to guide with the invasive procedures. And this is very convenient for unstable patients who cannot be transferred out from ICU for ancillary investigation. And in fact, I think in 2021, the European Society of Intensive Care Medicine has come up with a list of recommendations of what basic PoCUS skill an intensivist should equip himself with. And they come up with 49 strong recommendations. So based on that, what I'm going to highlight today, hopefully for the next 30 minutes, because we have up to 1 p.m. then, not 12:45 then. 1 p.m., very tough slot to deliver lecture before lunch. Okay. So I'm going to show how PoCUS can be helpful in managing respiratory distress syndrome or respiratory failure, utilization of PoCUS in shock, and then how to assess fluid status, and last but not least, the role of PoCUS in therapeutic monitoring and also guiding some invasive procedures. So I need to show some case. We have one case and a lot of clips, and all the clips are my personal collection. Throughout 24 years, and I'm in service in HKL. So I'm the oldest person here, I believe. So this is the outline, and I'm going to approach in intermediate level, meaning that I'm not going to give you a normal clips. They are all pathological clips. What more important is image interpretation and integration with the clinical syndrome without any advanced preparation. I know some of you are doing advanced, maybe UM is doing advanced because your intensivist is much into PoCUS. Okay. So my case, we have a 70-year-old man, hypertensive, diabetes, okay, and present with a fever and cough with pleuritic chest pain for 3 days. So let's look at the physical assessment. There are crepitation bilaterally, right more, from the left. Abdomen have a tender hepatomegaly, and there's mild pedal edema. Patient is hypoxic, hypotensive, and tachypneic, right? So how can PoCUS help to manage this patient? There's many protocols that we can use to approach the respiratory distress syndrome. One of the most commonly used is BLUE protocol, which is bedside lung ultrasound in emergency, introduced by Daniel Einstein in year 2008. He's the father of lung ultrasound. It is based on the presence of sliding signs and profiling of the lungs into A, B, or C to come into diagnosis whether the patient has APO, pulmonary embolism, or COPD, pneumothorax, and also pneumonia. Okay? And this protocol, if conducted by a trained personnel in 3 minutes' time without knowing the history or the physical assessment finding or point of care test can yield the diagnostic accuracy up to 90.5%. So it's quite reliable. So let's look at this patient. For the to simplify, I divide the lungs into 4 quadrants: right and left, upper zone and lower zone. Next zone, we will see the pleats. So this is the patient's lungs ultrasound: right, upper zone, lower zone, left, upper zone and lower zone. So what can we see here? Right. So what would be the diagnosis? We can see at the right upper zone there is shred sign, which is area of deaeration in the lungs. Okay, looking like shredded paper. Then, so this is the area of loss of aeration. And at the right lower zone, it's even worse. You can see the lungs looks like the liver. This is liver. This is the diaphragm. This is a spine sign. This is a positive spine sign, and you couldn't see any curtain sign. So this is the consolidation. This is what we call hepatization of the lung tissue, which denotes consolidation. Ini susah ni, 20 pun tak boleh buka. Okay. So at the left upper zone, we also see some hypoechoic area. This is also area of involvement of consolidation, subpleural consolidation. And you can see at the left lower zone, there is a collection of pleural effusion. And this correlates with the chest X-ray, which come much later, okay, after patient being intubated because he's hypoxic and has severe pneumonia. So these are the changes of pneumonia. Okay. These are what we call C profiling. So all these are C profile changes. So what are the lung ultrasound for APO? Right. So in APO, what you can see is the numerous B lines. This is B lines, okay, normally at the upper zone. And this is hemodynamic B lines. It is different from infective B lines. Because why? You can see the pleural line is smooth. It is not being irregular or jagged. It is smooth, and the B line is thin because it denotes alveolar edema. And the distance between one B lines to another is around 7 mm, which is equidistant to each other. But of course, if the APO is overt and severe, you can see confluent B lines. All the intercostal space become white and broad B lines. And if the patient has chronic congestion, you can see pleural effusion, okay, at the base with atelectasis. This is lung collapse. This is collection of pleural effusion. This is a positive spine sign. And because APO is a systemic problem, secondary to heart failure or kidney failure, so you should expect to see the similar changes in the other lungs, which is on the left. Okay? So on the left lungs, what you can see also B lines on the top and also collection of effusion at the base. So these are the changes of APO which correlate with this chest X-ray. Okay. So what about pneumothorax? So these are the cause of respiratory distress. So pneumothorax, this patient has right pneumothorax, not this case, but this is an example of pneumothorax. So if we put probe over here at the area of pneumothorax, what you can see on the B mode is absence of sliding sign because of separation of parietal and visceral pleural. So there's no sliding sign. Okay. Absence of shimmering. And if we convert the B mode into M mode, then we will see a barcode or what we call stratosphere sign. Yeah? And if we are lucky enough, we put the ultrasound probe on the meeting point of the normal lungs, aerated, and also the pneumothorax, we will see what we call lung point, when the normal lung meets with pneumothorax. And during inspiration, we can see, during inspiration, we can see the sliding sign. During expiration, there is absence of sliding sign. If we convert into M mode, then we will see the alternate seashore and barcode sign. So this is a pathognomonic for pneumothorax, but it's not easy to pick up. We have to scan a lot, numerous or many intercostal space to look for the meeting point. If the lungs totally collapse, you will not be able to see any lung point. Okay? So what if the lung ultrasound shows the normal lungs? Normal lungs denotes by the presence of sliding signs, A lines, And also at the base, you can see this is a diaphragm, curtain sign, and negative spine sign. You don't see spine here. And they are the same, right and left. So this is a normal lung ultrasound, but patient is breathless. So it is recommended for us to proceed with venous study plus focused cardiac ultrasound. Okay, and don't forget to auscultate the lungs. I have my fellow MO specialist and also master student MO doing lung ultrasound. And then, oh, I don't know why the patient is breathless when the lung scan are all normal. Then have you auscultated the lungs? Oh, okay. And patient has rongkai, berkus present. COPD je pun. Kan susah sangat kan? So don't forget to examine the patient. Ultrasound is just a tool. Okay? It's an adjunct actually. So in this case, we should proceed with expanded assessment of venous study. So this is, for example, of 2-point compression, where we put the probe onto a femoral vein and also popliteal vein. So this is a normal compression test in which right femoral vein is compressible. This is, for example, abnormal. You can focus on the left femoral vein. It is not compressible. So this is a positive compression test. You may not see thrombus in the vein because sometimes immature thrombus cannot be visualized in ultrasound. So it depends on the compressibility. It goes the same, complete the assessment, at least 2-point compression. I know some intensities do 5-point compression, which is better actually. But the rate of diagnostic accuracy is still more than 90% for 2-point compression. So this is right femoral vein and left popliteal vein, which is not compressible. So this is a positive. So in a combination of normal lung ultrasound, presence of DVT, and also plus a right heart strain pattern, which we will see afterwards, the diagnosis will be pulmonary embolism. Okay. So we know that blue protocol yield a diagnostic accuracy of more than 90%, but what about each diagnosis in isolation? So you can see here pneumonia, very high sensitivity and specificity, and you can even diagnose pneumonia with the presence of subpleural consolidation of Schreck sign only at the posterior part of the lungs. I have one patient over the last weekend when I was on call on Saturday. Big patient, you know, nowadays patients are all obese, 140 kg, female, took AOR from nearby hospital, not from Ampang, okay, and then was diagnosed as severe acute gastritis from where she took AOR. She took AOR because she cannot pay. Yeah. Then she brought the letter with a whole blood panel ready, including amylase and everything. The only abnormality was white cell count, 16.9. And she arrived in our resource sweating and with difficulty in breathing. So from far, apa sepatutnya diagnosis first yang kita perlu entertain. So for me, from far, I tengok obese lady, young, so PE is until proven PE until proven otherwise lah. So we approach the patient in severe pain, cannot take in, cannot inhale because it's very painful, and we managed to locate the site of the pain, which is under the left breast, left lower chest, and then we gave morphine, 5 milligrams stat, and she's a bit relaxed. Then we scan everything adjacent to the left lower chest, which include left kidney to look for pyelo, left lungs anteriorly, which is normal, the heart, of course, ACS, normal, there's no original wall motion, and basically everything was normal. Okay? Then a patient can sit up, so we scan the patient posteriorly. There is a large consolidation with parapneumonic effusion at the left base. So we were able to get the diagnosis within 15 minutes of arrival. That's the role of PoCUS in looking for source of infection or source of respiratory distress. And you can see here, APO, sensitivity and specificity are quite high. Total effusion lung ultrasound is very sensitive, can even pick up as little as 5 to 20 mils as compared to chest X-ray. Yeah. Pneumothorax, the presence of sliding signs exclude pneumothorax by 100%, but only at the exploit region because there is such a loculated pneumothorax. 2-point compression test performed by intensivists, is quick and has diagnostic accuracy of 95% compared to radiology. So you can do this in ICU to diagnose TB and subsequently. So remember this patient in shock just now. So what is the role of PoCUS in assessing shock in this patient? So there are also many protocols regarding shock, and one of the most commonly used is RUSH protocol, which is rapid ultrasound assessment in shock. Why do we need a protocol? It is just a roadmap for us to use and to guide us to scan in the heat of resuscitation, or else we will miss a major step and major finding. Okay? So this protocol is conducted to identify the cause of shock, provide treatment, and to reduce mortality rate. So it is based on assessment of 3 systems: the pump, the tank, and also the pipe, so-called. Honestly, adakah I use this RUSH protocol? I have my own protocol. After like 24 years, I have my own preference on how I do ultrasound for respiratory distress, for shock, and so on. And you, if you do a lot of ultrasound for quite some time, you have your own preference, a way how to scan the patient, right? Okay, but I don't have a Hidayah protocol or Hidayah's protocol lah, like that. So what are the pump, tank, and also pipe? Okay, the pump is actually referring to the heart. So we look at surrounding the heart, the left and right side of the heart. That is a pump assessment. For the tank, we look at the fullness of the tank by assessing the IVC or internal jug, and also the leakiness of the tank, looking at the potential space, which is the pleural, thoracic cavity and peritoneal cavity, and also compromised tank, which in the form of pneumothorax, and the pipe to assess whether there is any leakage or burst pipe or obstructed pipe lah. Okay. Jom kita tengok. You all nak jawab pun boleh je. Okay. Let's look at these clips. This is parasternal long, parasternal short, subcostal 4-chamber. Sometimes I put up typical 4-chamber and IVC. They are all the same arrangement, all the clips. So any abnormality here? Okay, kita pergi step by step. So the surrounding of the heart, there's no pericardial effusion. Left side of the heart, you can see LVH here. And the contractility, okay. So maybe I want to look at the contractility at its parasternal short. But I can see the RVs enlarged. The RVs enlarged. How do I compare? I compare to the LA and also the ascending aorta. And you can also see here the enlarged RV displace the interventricular septum into the left side. So making a D-shaped LV. Nampak tak? Okay. And if you see this, then you're lucky, but the patient is not. So this is what we call thrombus in transit. You can see thrombus in RA. So if your patient is hypotensive and hypoxic, and there is thrombus in the RA, confirm 100% PE. Okay, so this is what we call cardiac pneumonia or PE lah, thrombus in transit. But not many patients, you will see this. But if you see a patient with DVT, with right heart strain pattern, so most probably it is PE. And the IVC will be dilated because of increase in right side heart pressure. Okay? So the diagnosis is pulmonary embolism. Okay, so this is how we make the diagnosis based on focused cardiac ultrasound. Let's look at this one. Some of you would diagnose immediately these clips. Okay. So what you can see now, okay, remember to assess the pump, look at the surrounding. Is it normal? Of course, it's not normal. There is huge pericardial effusion surrounding the heart, which compress the RV. RV cannot open up during diastole to allow LV filling. Okay, and you can see the RV cannot open at the parasternal short and also apical 4. This is what we call dancing heart. And the IVC is dilated. So this is diagnosis, cardiac tamponade lah. What if the IVC is flat, not dilated? Have you encountered that? Itu soalan exam masters emergency medicine. In the presence of flat IVC with these changes, you might be dealing with patient with pericardial effusion plus hypovolemia. So the first step is to defib bolus. So maybe patient hypovolemic, so the pericardial pressure is so high that make the RV collapse. So give fluid. But if it is dilated, then don't waste time. Prepare for pericardial symptosis. Okay. So you're dealing with cardiac tamponade. What about this one? Patient sudden onset of chest pain, sweating 2 hours prior to this is ED prior to arrival, but it can also happen in ICU, complaining of severe chest pain. So what we can see here, looking at the surrounding of the heart, there is no collection. Looking at the LVs, is it normal, the LV? No, it's hypocontractile, abnormal contractility, especially at the ear interventricular septum. Okay? And you can see here there is lack of movement, hypokinetic segment here compared to the posterior part of the LV. And also here, you can see the RV is trying to compensate the inactive LV. Dia sorang-sorang je buat kerja. Ni relax ni. And IVC is so and so. So on ECG, this patient exhibit ST elevation, MI at the LAD pattern. So this is a cardiogenic shock secondary to acute STEMI. So LV failure. So these are the changes of. So what about this? So you can see surrounding of the heart, there is no collection. The LV looks dilated. The LA also looks dilated. But the RV, okay, I always compare, I always go to the next clip when I suspect abnormality in the RV. So enough here, you can see there is enlarged RV and also flattened the IVS. And you can see hypokinetic RV here and also dilated. And IVC is dilated. So on ECG, this patient has inferior STEMI with RV infarction. So this is the patient with cardiac shock with RV failure. So these are the features. These features also you may encounter in patient with pulmonary hypertension. But how to differentiate? Then you have to do some calculation to measure the pressure in the RV or pulmonary artery. So in a pulmonary hypertension, then the pressure will be high. In the patient with acute STEMI, the pressure will be normal. Okay? And what about this one? This is very common, like, yeah. Look at surrounding the heart to assess the pump. There is no collection. You can see the heart is hyperkinetic and hyperdynamic. Okay. And when you see the LV area during diastole, here is small, meaning that there is no LV filling during diastole. So the LV cannot comply and smaller. And you can see here the RV, small, LV point small, IVC, totally collapsed. And these are the pattern of hypovolemia. This is the pattern of hypovolemia. So with PoCUS also, we can look for the source of hypovolemia. For example, any leaking or loss at the potential space. This is collection in the right pleural. If this is a trauma patient, this might represent pneumothorax. Okay. And this is intra-abdominal collection, spleen. This is collection above the spleen. Okay. Free fluid intraperitoneal. Kalau trauma, then this is intra-ab injury. If patient is pregnant, EPT positive, maybe ruptured, hot quick pregnancy. Okay. And you can also assess whether the pipe is leaky or not. For example, this is intimal flap of the thoracic arch. This is aneurysm or dissecting aneurysm. Okay, and this is triple A. Okay, this is triple A. So you can look for source of hypovolemia. So for all those type of shock, pulmonary embolism, cardiac tamponade, hypovolemic shock, cardiogenic shock, if if we measure the stroke volume or the surrogate to stroke volume, which is LVOT-VTI, it will be a low cardiac output, okay, less than 70. Okay, what about this tape? You can see there is no collection surrounding the pump or the heart. The heart is a bit tachycardic, hyperdynamic, but the LV size during diastole is normal. Okay, and the LV and RV also well filled. IVC is not collapsed. So, what are the shock that we are dealing with? Contractility is not a problem. Preload is also not a problem. Okay, so the problem with this patient can be deducted from the formula. Easy. Cardiac output equate to stroke volume times total peripheral resistance. So we know that stroke volume, if we can measure the stroke volume for this patient. If that's a distributive shock, we can measure the stroke volume looking at the LVOT-VTI as a surrogate. So if let's say the stroke volume is normal, here is 23.49, it is supranormal. LVOT-VTI normally is 20 plus minus 3, so 23 is above normal stroke volume. Heart rate is normal just now. So once the BP is low, then the problem is the total peripheral resistance. So that is the features of distributive shock, whereby you don't see any contractility problem or preload problem. So the problem is the afterload. So this is by deduction. You can actually measure the SVRI, but you need some formula and advanced calculation. Right. So how to differentiate between hypovolemic shock and distributive shock? So simply by looking at the LV area during diastole and systole. This is hypovolemic shock because there is not enough preload. There's no LV filling. So during diastole and systole, both are small. But in the vasoplegic or distributive, with adequate fluid status, the LV area during diastole enlarge, but during systole small because the LV is contracting against a very low resistance. So hence dia eject out a supranormal stroke volume. So this is by qualitative sahaja. Tak perlu measure. That's how we differentiate. So this patient with distributive shock, the treatment is not tweak, the treatment is vasopressor. Okay. So once you encounter a distributive shock patient, a specific patient with sepsis, then we can look for the source of infection. For example, in this case, that is a vegetation at the anterior mitral valve leaflet at the low pressure area, which denotes infective endocarditis. And that is a sludge in the gallbladder with a gallbladder stone. That is one of my patients, datang recovery UTI, sentiasa, and tak resolve. And this patient has bladder diverticulum, which is a source of non-resolving infection. And this patient, we thought the patient has phyllo because right flank pain and there is evidence of hydronephrosis. Okay, but upon sliding down the probe towards the caudate, we see collection of abscess in the psoas muscle. There is psoas abscess, compressing the ureter, causing hydronephrosis. So you can look for the source of sepsis. So RUSH protocol outline the changes of pump and tank and pipes for each of the type of shock. So hypovolemic, small, LV and RV size, IVC flat, and maybe there is burst pipe in the form of AAA or dissection. Cardiogenic, of course, contractility is affected, whether left or right. Okay, and the IVC would be distended, and the pipe would be normal. In obstructive shock, for example, you can have a pericardial effusion in the case of cardiac tamponade, right heart strain pattern in a pulmonary embolism. Okay, and hypercontractile of the heart because of low cardiac output. Distended IVC, and in pneumothorax, maybe absence of sliding signs, and DVT as a source of embolism. Distributive shock, early phase, you will have hypercontractile heart, but late stage, maybe septic myocardium has set in or myocardial depression. Okay, normal IVC, maybe you can find a pleural fluid or peritoneal fluid as a source of infection in a patient with empyema or patient yang on PD and so on. The pipe will be okay. So what is the diagnostic capability of PoCUS in diagnosing shock, PE, any absence of RV strain pattern in patient with hemodynamic instability, unlikely PE. Unlikely PE. Okay, cardiac tamponade, RA systolic collapse is actually the earliest sign, 100% sensitivity in the late phase. We normally look at the RV because it's more clear than the RV. Cardiogenic shock has very high negative predictive value. If the heart is normal, then it is not cardiogenic shock. POCUS, not so high sensitivity because it is being influenced by obesity, the presence of subcutaneous emphysema, and also ascites. We don't know whether this is ascites or blood actually in trauma patient. For example, trauma patient with institutional failure. So you don't know the fluid collection is ascites or blood. AAA, if you complete assessment from the epigastric region to the bifurcation of the iliac artery, okay, looking at dilatation more than 3 will give sensitivity and specificity up to 100%. Okay. Okay. So far, any question? PoCUS in respiratory distress and shock. Do you do this in ICU or patient ICU dah masuk ED dah buat dah semua? But if the patient develop new shock or hemodynamic instability, then you can do this actually. Okay. Any question? Tak ada. Okay, back to the case. Remember, this case has severe pneumonia and the heart is just like this. Okay. Heart, dilated LV, dilated LA, abnormal contractility, RV pun COM, so biventricular failure. And remember, this patient is dehydrated and hypotensive. Are you going to give fluid for this patient? Siapa yang akan bagi fluid? I think most of us akan bagilah, but how much is the question? Right? How much and how fast is the question? This patient is dehydrated. Okay? But most probably, looking at the heart function, patient will not respond to fluid. Okay? So, how can PoCUS assess fluid status in a patient? Fluid status are usually divided into depletion, responsiveness, tolerance, and also excess. Okay? Depletion, kita boleh assess from physical assessment, history, and also PoCUS. Remember the hypovolemic shock features just now? Okay? And responsiveness, how do you gauge whether this patient akan respond to our fluid resuscitation or not? So we have to study the heart, where the heart sit at this Frank-Starling curve. And this is a normal heart with good LV function, whether the patient sit at the steep curve, which is fluid responsive, or at the euvolemic curve, or at the hypervolemic curve. So macam mana kita nak tahu? Simple, there is a lot of parameter that can gauge where the patient sit on the curve, but we can use the LV and diastolic area. So if we scan the patient at parasternal short axis with good contractility, the LV area is small. The chance is the patient will be fluid responsive, meaning that there will be increment of throat volume by 10 to 15% with fluid bolus. Okay, so you boleh bagi fluid lah. Kalau dapat LV area macam ni, dia akan improve jadi lagi besar. But if when you scan the patient, the LV area is already enlarged macam ni, even though with good contractility, the chance is with similar fluid bolus, it will not give any response in the stroke volume. So the shock is due to other things. It's not preload. It's not hypovolemic. Okay. So what if the patient has abnormal contractility, just like our patient just now, right? Case. So the Frank-Starling curve will be depressed here. So any fluid boluses, we will not get a response. So clearly that patient just now will be not responsive. Okay? So what do? We have to support the patient. We have to improve the line up here by giving inotropic agent vasopressor is the first line, alright? So that the contractility improves, then you can give fluid after that. So that's how we do it. Okay. So once we have ascertained the patient's fluid responsiveness, now we want to assess the fluid tolerance. And fluid tolerance is defined by the ability of the organ to tolerate fluid before it goes into dysfunctional. Okay, and each organ has a different fluid tolerance. The heart is different, the lungs, the kidney, and also the liver. And you can see here the window of euvolumic will be narrow in the presence of kidney and heart failure. So there's a lot of assessment, but we can focus into the major organ. For example, the LV, both systolic. You have seen the Frank-Starling curve just now. Okay, diastolic dysfunction also, influence tolerance, the state of the RV, the lungs, and the kidneys. Okay? So LV diastolic dysfunction is very important for ICU patient because it gives you understand what are the fluid limitations for this patient. So we can do transmitral inflow to get the morphology of the Doppler wave. This is normal and these are abnormal. And from this also we can measure the LA pressure because LA pressure is equate or correlates to E over E prime, which we can measure in the echo. So if it is low, we can give fluid safely, but if it is high, more than 12, then we have to be careful because more than 18 LA pressure, you will see B lines, wet lungs. So in other words, kalau tak pandai buat echo, you can scan the lungs to look for the presence of B lines, which indicates fluid lah, wet lungs. Okay. So fluid administration limited by lung sonography is another method of giving fluid. So LV intolerance, apart from being influenced by systolic and diastolic, it also influenced by the structural abnormality. For example, in this case, okay, clip A shows severe LVH, most probably cardiac amyloidosis. B, severe mitral stenosis, causing huge LA. So this was my patient, seorang pakcik ni, dia default treatment dekat Serdang and came with heart failure. And we scanned the patient, the LA is huge, okay? More than the other chamber size. Siap kat sini. You remember. The presence of regurgitation, this is MR. So you may want to limit fluid and put the patient on tachycardic side a bit because you want to reduce the regurgitation time, which will congest the lungs. And this patient has lung CA, which intrude into the LA and influence the fluid tolerance. So there's a lot of things that you will find once you be familiar with the ultrasound. So these are the example of RV intolerance. You can see the standard or enlarged RV here. RA is enlarged with abnormal contractility. If we give fluid here, the RV will become more distended and it will reduce the perfusion to the RV during diastole especially and cause RV ischemia and crash the blood pressure further. This is a presence of tricuspid regurgitation, severe. IVC distended is another features of right heart strain pattern, and this is pulmonary artery, main pulmonary artery enlargement as compared to the aortic valve here. So those are the signs of RV intolerance to fluid. So in the presence of these signs, you may want to cut down the fluid. Kidney intolerance, you can scan the kidney looking at the size and the echogenicity. This is hypoechoic, very small, shrunk kidney, clearly end-stage failure. Tak payahlah tunggu RP ke apa ke. Okay. ABG diacidotic semua. And this is hydronephrosis. Siapa yang buat VACSes in your ICU to gauge how much fluid to be evacuated from failure patient? Do you do it regularly? VACSes. I have some friends, especially nephrocritical care friends, who are doing VACSes on their patients to assess how much of fluid they want to extract during dialysis. So this is the assessment of each organ, venous system to see whether they are congested or not. The heart represented by IVC diameter of more than 2. The liver represented by hepatic vein, morphology of the S and D wave. Okay? Abnormal S and D wave means congested. The portal vein, which represent the splanchnic circulation, okay, by looking at the pulsatility index and also the renal vein, we look at the diastolic monophasic flow. So if the IVC is extended more than 2 with the presence of 2 abnormality, it equates to severe congestion and you have to evac the patient. Okay? So in short, the fluid assessment. Okay? So if the patient is hemodynamic unstable, fluid depleted, you can give fluid, but still he remain unstable, then we have to look for fluid responsiveness test. If patient, for example, our patient just now, fluid responsiveness, no. Fluid tolerance, do you think the patient can tolerate fluid with that severe pneumonia? No, even though it's no B lines like inflammation can cause pulmonary edema and so on. So if no, then we have to support the heart and conservative fluid, no boluses or whatsoever. Yeah. So that's how we assess fluid status, responsiveness and tolerance in critically ill patient. If let's say the heart is good, the lung is normal, kidney is okay, they are the GI sepsis, then give fluid. If let's say the heart is abnormal, but the rest of the lungs and kidney are okay, then support the heart and do a fluid responsiveness. If they respond, then give fluid. Okay? But if you assess there are fluid excess evidence, then support the heart and evacuate using VACs. Okay, so this is for our patient just now. Okay, we are at the final part. Maybe I'll go very fast. What are the role of point-of-care ultrasound in therapeutic monitoring and also invasive procedures? I think 10 slides. So this is another way of doing lung recruitment. I think Dr. Po just now talked about the ARDS lung recruitment. This is another way to look for the opening pressure and closing pressure. So this was me and my colleague, and this is Dr. Sharidan, anesthetist from Madini now, working in Madini, regionalist. He came for CSR lah, okay, to HKL when we were hit by COVID. We have in ED 400 patients, COVID patients, 40 intubation at one time. Lebih daripada ICU, 40 intubated patients. And we recruit patients using a handheld ultrasound. So this patient, okay, how do we know that the lung is recruitable? Okay. For example, this is Schreck sign. So once we increase the PIP, okay, and the C profile turn to B profile, the lungs open up. And if we increase some more, the PIP or CPAP, okay, it turns to A profile with 1 or 2 B line. So these are the changes of lung recruitment. And this process, okay, is based on the finding, which is highly significant correlation between CT scan and lung ultrasound on re-aeration score before and after antibiotics, found by Bohemet in year 2011. So we can actually detect the opening pressure of at the ascending limb. So this is the opening pressure, whatever peak we give here, and the closing pressure. Okay. So Tasman et al. Recommend 4 steps of lung of recruitment maneuver using PoCUS. First, look for area of deaeration. If yes, check the hemodynamic. You can check the fluid, the contractility, and so on. Okay, settle these issues. And then number 3, do recruitment. Find the opening pressure here where the C turns to A profile. Then when you reduce the PIP, you can look at the closing pressure when the A turns to C profile. So that's how we use ultrasound to recruit the lung. One of the ways. There's a lot of methods. Okay. What else that we can do? So weaning, as Dr. Chin mentioned just now, we can actually assess the diaphragm to gauge whether this patient, to predict the weaning from mechanical ventilation. This is non-invasive visualization. What we can do is, one parameter is diaphragmatic excursion. We can use abdominal probe or cardiac probe and mode. So normal excursion from inspiration to expiration is around 2 centimeters. Okay, the dysfunction would be the excursion of less than 1.5 centimeter. Okay, if the diaphragm during the SVT move paradoxically, it means that it is paralyzed. So you can use this as the method of weaning, one of the factors, not the factor. And another method is to look at the diaphragmatic thickness fraction during inspiration and also expiration. So we look at the diaphragmatic thickness during peak inspiration minus the during end of expiration, divide by 100. Normally, because the right lungs normally is different from the left lung, average around 35 to 50% normal. If it is less than 33%, it predicts weaning failure. For ED, less than 20% predict NIV failure. So that's how we can use PoCUS to assess weaning. Another way of PoCUS utilization is that we can assess the cerebral circulation. Siapa yang pernah buat TCD? TCI tak pernah. So I pun jarang buat lah sebenarnya. Okay. Mainly we can assess the midline shift, vessel spasm, intracardiac pressure, and also patient yang brain dead. Okay. How do we do it? Cardiac probe with TCI or TCD application, letak dekat temporal sebelah sini. Look at the contralateral temporal bone and also third ventricle as the midline structure, and then put color to pick up the MCA and the rest. The MCA yang normally akan senang pick up. So when we have pick up MCA, put Doppler, and this is the Doppler wave of normal MCA. Peak systole and deceleration of diastole. So in the presence of midline shift misalnya, so we can measure from the ipsilateral temporal to the third ventricle, and then change the probe to the other side. We measure again the difference, divide by 2, that is the midline shift. So this correlate with the CT scan later on, tepat 7 mm. Jadi kita measure. Okay. So another role of TCD is to measure the ICP. Okay, so this patient with a subarachnoid hemorrhage, diffuse, there's blunting of diastole and peaking of the systole. So the ICP based on the this formula, because we can measure the pulsatility index, okay, is high. So this is after intervention. So kita repeat balik semula. There is normalization of the diastolic wave. Okay. So that is another way of PoCUS. Okay, ultrasound guided procedures, I'm sure you are very well versed. Do you do CBL with ultrasound nowadays? 100%, kan? 100%. So we can actually use ultrasound in a real time and as a static marker. For example, this is parasternal approach of pericardial synthesis. We do pericardial synthesis using ultrasound guided. So one line, okay, ergonomic, the patients, the probe, the eye, and also the ultrasound. So this is the chest wall, this is the myocardium, and that is the pericardial effusion. So you can see we puncture here, okay, tip of the needle, confirmed by giving agitated saline and that is a guide wire. It's quite safe. We have done like 40 patients in our EDHKL without any complication. So this method was introduced by Dr. Adi Osman, my senior in emergency critical care in year 2017. Okay. Another way, this is the last slide, I think, airway landmark. So you can actually identify the tracheal ring there, surrounded by the isthmus and also the thyroid gland. Clip B shows ETT passing through the trachea. You can confirm intubation by using ultrasound. Clip C is an ETT passing through the esophagus. Right, so you don't do this, not recommended in ICU, you have DAL and everything. But here you can identify the cricothyroid membrane, the area for cricothyroidotomy, and you can even assess patient's vocal cord, whether there is paralysis or not. That's my vocal cord. As a sample for today's lecture. Okay, like that. Ada paralysis. And for ICU, per trachea, normally you do at the in between T2 and T3. So you can identify T2 and T3 in an obese patient or in anatomically distorted patient using ultrasound. Okay. So I think that's it, the role of PoCUS for ICU. There's many other roles advanced with a calculation, and I believe PoCUS in ICU is indispensable, and it should be a common language between a resuscitationist and intensivist. I consider myself as a resuscitationist. Okay? And if there is barrier, I think it is due to training. Nowadays, emergency medicine, they have ultrasound curriculum is a must, and they have 1 month or 2 months attachment to do only ultrasound. And ultrasound should be treated as the 5th pillars of examination, yeah? Supplementing the inspection, palpation, auscultation, and also percussion. So the last one is insufflation. With that, thank you. I think it's time for lunch break.